So good afternoon, everyone. Thank you for joining us for today's webinar, Benzodiazepine 101, Facts, Myths, and Safety. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of our presenter. Please submit your questions using the Q&A function in the Zoom toolbar at the bottom of your screen. Click on Q&A, type your question, and hit send. We'll address these questions as time permits during the Q&A portion at the end of the presentation. We are offering CME, Social Work CE, and McBAP credits for today's webinar. We'll have a slide up with information about obtaining these credits during the Q&A portion of the webinar. We will also email the continuing education information after the webinar today. My name is Katrina Hernandez, and I am an engagement specialist with OPEN. The Overdose Prevention Engagement Network, OPEN, is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative evidence-based solutions to reduce harm and stigma surrounding substance use, we work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect prescribers to our addiction medicine experts who provide guidance for managing patients who have substance use disorders or complex pain and can answer both individual treatment and technical assistance questions. We offer expert-led education and training sessions. All of our webinars offer free CME, CEU, and McBAP credits, and for prescribers, all our credits also qualify for the DEA required SUD training. We provide MOUD training for physicians, and this year we are incentivizing primary care providers with $250 to complete one of our MOUD trainings to encourage confidence and willingness to help expand access to MOUD treatment. To prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide data to inform opioid prescribing. You can access more information about all of these services more directly using the QR codes or visiting our website. OPEN also provides tangible tools to reduce harms of opioid and substance use, and our hope is to disseminate resources to places that need it most. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based printable educational materials for both patients and providers. Patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. Provider education supports best practice implementation for primary care, acute care, obstetrics, pediatrics, and dentistry. We provide safe medication storage and disposal options. We assist groups across the state in hosting local medication take-back events. We fund implementation of permanent medication disposal boxes for qualifying applicants, and we provide charcoal disposal bags and medication lock bottles for healthcare and community distribution. For overdose rescue support, we fund implementation of naloxone vending machines and distribution boxes, and we offer naloxone administration trainings. These trainings are offered as live, virtual, or free online training courses. No planners, faculty, or others in control of content, either individually or as a group, have relevant financial relationships with ineligible companies. I will introduce our presenter for today. So Elizabeth Liz Hoffman, MD, received her BA in psychology from Kenyon College and her MD from Loyola University in Chicago. She completed her residency in internal medicine and psychiatry at Duke University and subsequently joined the faculty at the University of Michigan in 2021. Dr. Hoffman is board certified in internal medicine, psychiatry, and addiction medicine. She splits her clinical time between hospital medicine, psychiatry consults, and addiction consults at Michigan Medicine. And with that, I will turn it over to you, Liz.
I have no relevant financial disclosures. I do refer to brand names and off-label uses throughout this talk, but only for teaching purposes. Here are my objectives for today. Given the limited time, I'm really covering the basics of benzodiazepines, including a little bit about their background, pharmacology, and the indications for use in clinical practice. some general concepts related to tolerance, dependence, and withdrawal, and importantly, how we distinguish between benzodiazepine dependence and benzodiazepine use disorder. I'll also be discussing the American Society of Addiction Medicine's recent guidelines that came out for tapering benzodiazepines. I'll start with a case. Pam is a 38-year-old woman with no significant medical history who presents to clinic endorsing 2 months of anxiety related to work and child-rearing responsibilities. She's difficulty sleeping due to racing thoughts, some muscle tension, intermittent irritability, and difficulty concentrating. She's not interested in a daily scheduled medication, but wants something to take as needed. She's heard from friends that alprazolam or Xanax works well and doesn't leave them feeling tired or unable to function. So Pam is requesting a benzodiazepine. So, these clinic visits may fill you with some apprehension, some dread, ambivalence, and I'm sure many of you have faced this scenario. And because we all know a bit about benzodiazepines already, some of the questions we may be asking ourselves include, what is her underlying diagnosis? Is a benzodiazepine clinically indicated? What are the potential risks and benefits of a benzodiazepine for Pam? And also we might be thinking, if we provide her with a script today, how long do we expect her to stay on this? Will it be a challenge to get her off this medication? Barbiturates predated benzodiazepines as one of the primary tools physicians had to treat anxiety and stress in the first half of the 20th century. As you can see, these medications were primarily targeted towards women and their heightened emotional states, but barbiturates were known to be addictive, very sedating, with a narrow therapeutic index, and had multiple drug-drug interactions. So there was an effort to discover another agent with a safer profile. Chlordiazepoxide, or Librium, was introduced in 1960 primarily as an anxiolytic, but it was also marketed to psychiatrists as a medication to reduce agitation and tension in order to make patients more malleable in psychotherapy. You can see they continued to target women primarily throughout their campaigns, particularly mothers hoping to better manage the work-life balance. What made benzodiazepines so versatile was that they were able to discover a basic structure, a benzene ring fused to a 7-member diazepine ring, and then determine that a single modification to the ring system could yield a brand new compound with slightly different properties that could be marketed all on its own. So diazepam had a 1-methyl derivative that yielded more intense muscle relaxant properties, and that came out in 1963 as Valium. And there have been many iterations along the way. A very quick and basic explanation about what benzodiazepines do. They bind the GABA A receptor and increase the frequency of the chloride ion channel opening, which leads to an influx of chloride, overall reducing excitability at the neuron. It's like pumping the brakes in the central nervous system and making it less responsive to other neurotransmitters like norepinephrine, serotonin, dopamine. Benzodiazepines are highly effective and are FDA approved for a number of different psychiatric and medical conditions. The most common uses for a benzodiazepine are anxiety and insomnia. And it's a very commonly prescribed psychotropic. So in 1977, Valium and Librium were the first and fourth most commonly prescribed drugs in the US, used by 1 in 10 adults each year. There was a decline after the 1970s due to growing recognition of dependence and withdrawal risks, some negative public perception, state-level regulations, and the emergence of alternative psychotropics like SSRIs. Between 1996 and 2013, the number of U.S. adults who filled benzodiazepine prescriptions increased by 67%, and the total quantity of benzodiazepines more than tripled. This was largely driven by primary care providers providing patients with more pills each fill period and prescribing for a longer duration of time. In fact, between 2014 and 2016, almost 90% of ambulatory visits during which a benzodiazepine was prescribed was for continuation rather than a new start. And the majority of those benzodiazepines were short-acting, like alprazolam or Xanax, for example. Since 2018, the overall trend in prescribing has decreased. Older adults, specifically adults over the age of 56, receive the most prescriptions for benzodiazepines. Approximately 5% of older adults received a script in 2022, while young adults between 18 and 35 were the least likely to receive a benzodiazepine script. We know that there's a risk of addiction associated with these medications, but in fact the majority of individuals who are prescribed benzodiazepines use them as instructed without escalation in dose over time. This study was done by colleagues at the University of Michigan in 2019. They found that young adults 18 to 25 were the most likely to misuse a prescription benzodiazepine, and that risk decreased with age, although the overall use was highest in the 50 to 64 age group. They also found that prescription opioid and stimulant use disorders were most strongly associated with benzodiazepine misuse. We know that benzodiazepines carry risks, in particular drowsiness, sedation, falls, cognitive impairment. Over time, people can develop impairments in attention, working memory, and processing speed. Elderly people, particularly those with dementia, may experience paradoxical reactions like worsening agitation. During that period between 1996 and 2013, when we saw a significant rise in the number of benzodiazepine prescriptions, we also saw that ED visits related to benzodiazepines tripled and overdose deaths quadrupled. Now, the majority of these fatal overdoses involved benzodiazepines in combination with opioids, many of them prescribed. And luckily, that did start to turn a corner in about 2018 or so. One of the things I find fascinating is that actually it's more common for a fatal overdose to co-involve a benzodiazepine than alcohol. Benzodiazepines on their own are not likely to result in respiratory depression and death. However, when combined with CNS depressants, they can be extremely dangerous. So the FDA came out with an updated black box warning in 2020 stating that benzodiazepines can be an important treatment option for treating disorders. However, even when taken at recommended dosages, their use can lead to misuse, abuse, and addiction. Misuse can result in overdose or death, especially, again, when combined with other medications like opioids, alcohol, or other drugs. And physical dependence can occur when benzodiazepines are taken steadily for several weeks to days, and abruptly stopping or reducing the dose too quickly can result in withdrawal reactions, including seizures, and be life-threatening. Okay, so back to PAM. Is a benzodiazepine indicated for PAM? Possibly. But before we move on, we want to have some clarification on what's going on. And it's outside the scope of this talk to address the psychiatric differential diagnoses, the potential risks and benefits to her specifically. We want to look into, and we want to establish a time frame for use and be transparent with her about a plan. I will say generally that in my experience, benzodiazepine prescribing is very provider dependent, but I think that there are some safety and harm reduction strategies that are worth discussing. So like I mentioned earlier, we have a variety of benzodiazepines to choose from. The main differences lie in their time to effect, their metabolism, and elimination half-lives. The mnemonic LOT reminds us that lorazepam, oxazepam, and temazepam are safest in patients with cirrhosis or liver dysfunction. The short-acting benzodiazepines like alprazolam or triazolam tend to be more reinforcing and much harder to discontinue the longer someone is on the medication. Xanax works very, very well for anxiety, and over time people feel very uncomfortable without it, which drives its further use. The longer-acting agents tend to be less reinforcing, particularly those with active metabolites that have very long half-lives, like chlordiazepoxide or diazepam. Although I have had some patients on long-term diazepam that have had difficulty coming off. In terms of benzodiazepine prescribing, it's reasonable to prescribe a short-acting benzodiazepine for something like an MRI or an outpatient medical procedure, or provide a small supply for things like flying. But in general, benzodiazepines are not recommended for chronic long-term use or recommended monotherapy for diagnoses like anxiety or insomnia. They do not improve a patient's quality of sleep. They're not recommended at all for patients with PTSD. Sometimes psychiatrists or primary care providers will provide a short 2 to 4 week script while initiating another appropriate treatment like SRI or SNRI or CBT, with the clear understanding that this is intended to be short term and there's a clear end date. But it's important to establish an end date from the beginning. With chronic use, the short-acting benzodiazepines are the hardest to get off of and yield more protracted withdrawal symptoms. If monotherapy is felt to be appropriate, we really should be referring to psychiatrists or other appropriate specialists to manage while documenting intolerance to or poor response to first-line treatments, documenting the benefits and the risks, and using the lowest effective dose. It is very important that benzodiazepines not be co-prescribed with opioids, and we need to use caution and counsel against use with other CNS depressants, including things like muscle relaxants, neuropathic agents, sedating psychotropics, antihistamines, alcohol in particular. We should be screening for substance use disorders because folks are at higher risk of misusing benzodiazepines. I know sometimes there are patients with severe anxiety who turn to alcohol as a way of coping in lieu of access to benzodiazepines, and that sometimes benzodiazepines are started in an understandable effort to help the patient cut down on alcohol. And I would say that if after a few months the patient isn't able to establish abstinence or significantly cut back, then those should be tapered off. It's important to utilize the prescription drug monitoring program, both looking for other providers who are writing scripts or other CNS depressants, and then also remember that patients on methadone for opioid use disorder will not show up on MAPS or PDMP because it's dispensed, it's not prescribed. And we need to know and utilize urine drug screens and confirmatory testing, as well as tests for alcohol use if appropriate. You have to know what your drug screens are evaluating for. Often a urine drug screen will show positive for a benzodiazepine, but it will not be detected by the confirmatory GCMS or gas chromatography mass spectrometry. You can order a benzodiazepine confirmatory test, which is separate, but it may take several days to come back. And there are false positive benzodiazepines or medications that will falsely make a benzodiazepine positive. So things like sertraline, fluoxetine, trazodone, things like that. Okay, so back to Pam. So you determine that Pam suffers from generalized anxiety disorder. You refer her to psychotherapy and start sertraline, which is an SSRI, with a plan to titrate up over the course of a few weeks. You provide a short prescription for lorazepam, 0.5 milligrams daily is needed for 15 days, and you request that she return for follow-up in 1 month. Unfortunately, Pam does not return for her follow-up appointment and does not respond to letters. 18 months later, Pam presents again to your office after having moved out of state for some time. She reports that she's been prescribed and taking alprazolam or Xanax 2 milligrams 3 times daily from an out-of-state provider, which you're able to verify in the PDMP. Her last prescription was 5 weeks ago, but she ran out 2 days ago because she's been rationing, and she is endorsing several symptoms of benzodiazepine withdrawal, including sweating, anxiety, insomnia, irritability. So benzodiazepine withdrawal is very uncomfortable. Because of the lack of GABAergic inhibition, people are in a heightened state of excitability, anxiety, irritability, agitation, insomnia. It is less common to see hypertension and tachycardia in early benzodiazepine withdrawal compared to alcohol withdrawal. It's more delayed, and it may be a little harder to identify objectively. In severe cases, it can be deadly. People can have seizures, delirium, cardiovascular collapse. So there are no validated scales for monitoring benzodiazepine withdrawal. We frequently use the clinical alcohol withdrawal assessment scale as a frequent substitute. I know that a couple of benzodiazepine withdrawal assessment scales are in existence. CWA-B is one of them. It was developed in 1989 and was based on a small cohort study of 63 individuals. The only objective clinical measures are restlessness, agitation, tremor, and sweating, and the remainder are patient-reported symptoms. Interestingly, when I looked up CWA-B in PubMed, there were only 6 papers referencing this, and there are no validated symptom trigger dosing algorithms based on the tool, so I've not seen this used in practice myself. The Benzodiazepine Withdrawal Symptoms Questionnaire is another available scoring system, really nonspecific, and again, doesn't guide how to treat. It just says if you have a score greater than 20 to seek specialist medical help, and I've not seen this used in practice either. So this is a nice table from ASAM that can help to guide us in terms of the risk of withdrawal. So if someone is using benzodiazepines 3 days a week or less, they're unlikely to experience clinically significant withdrawal with abrupt discontinuation. In terms of regular use, at least 4 days per week, withdrawal can occur after only 2 to 4 weeks of treatment. Again, the longer someone is on a benzodiazepine, the higher the chances of withdrawal with cessation, and the more unpleasant it is and the harder it is to get off. So you might be wondering if Pam has a benzodiazepine use disorder. Dependence does not equal a use disorder. So nearly all patients develop physical dependence after 4 weeks of regular use, even when taking benzodiazepines as prescribed. It's just the nature of the medication and how it works physiologically over time. Thankfully, less than 2% of patients who are prescribed benzodiazepines develop a use disorder or addiction. The official way we diagnose a benzodiazepine use disorder is by using the DSM-5 criteria. Primarily, we diagnose a use disorder if use leads to significant impairment or distress, as evidenced by at least 2 criteria. It's important to remember that tolerance and withdrawal do not count as criteria if the medication is prescribed, because again, that is the nature of the medication itself. The hallmark criteria of addiction are the 4 C's. So compulsion, an absolute and overpowering urge to use, craving, the physical manifestation of that intense desire to use, continued use despite negative consequences, often in multiple domains of life, and difficulty controlling or cutting down on use despite those significant consequences. In 2025, ASAM came out with a joint guideline on benzodiazepine tapering. This is not meant to be a one-size-fits-all approach or mandate. We all saw what happened when the opioid guidelines initially came out and people were getting cut off. The guideline does recommend that providers not abruptly discontinue, but taper prescribed benzodiazepines for anyone on multiple agents, anyone on high doses of benzodiazepines, anyone co-prescribed opioids, or anyone with an active substance use disorder. In addition, because of the rise in the risks as people age, they recommend tapering benzodiazepines for adults over 65 unless there are compelling reasons to continue and the benefits outweigh the risks. We really want this to be a transparent, patient-centered process. Consider a dedicated visit to engage in a two-way conversation about the patient's goals long-term, the risks of the individual's current regimen. We may need to engage in motivational interviewing to determine readiness. If the patient is in agreement, we want to provide a detailed written plan and instructions, but also discuss how you will monitor and assess symptoms of withdrawal and what you plan to do. You may need to change course and be flexible throughout the process. We do really want to be careful, especially when caring for our patients with substance use disorders, that we're not stigmatizing them. We don't want to just cut people off. We want to be thoughtful about prioritizing safety and engage in a shared decision-making model as much as possible. Patients have reported feeling that their withdrawal symptoms were ignored or misattributed to recurrence of symptoms for which benzos were started in the first place. And it can be really tricky when we as providers feel very strongly and our patients do not agree with the plan for taper. In those circumstances, we want to hear people out, really understand their concerns and listen. We want to check our biases and make sure we are not making a decision based in stigma or treating people unfairly. It's important that we be transparent but also flexible throughout the process and possibly slow down a taper if it's not going well. In very extreme cases, patients may threaten legal action, mood decompensation, or even suicide. And it's reasonable to provide a referral for a second opinion and also confer with your institution or center's legal counsel or risk management. And of course, we want to document very clearly. In terms of the actual process, like I've mentioned, we never want to stop abruptly. So ASAM recommends approximately 5 to 10% reduction per week. So you can imagine that in many cases, this can take many months. But in cases where the risks significantly outweigh the benefits, a more rapid taper may need to take place. This can't always be done in the outpatient setting if patients have active withdrawal symptoms, particularly any autonomic or neurologic findings, or comorbid substance use disorders, particularly alcohol use disorder, any prior episodes of complicated withdrawal or medical complexity. They likely need a higher level of care, in which case you may need to even send them to the emergency department or a dedicated medical detox center. So there's no FDA-approved medication for benzodiazepine withdrawal or benzodiazepine dependence. There's a lot of flexibility here in terms of the specifics of management. And depending on what the patient's on, particularly if they're already on an intermediate or long-acting agent, you can consider a slow taper of the existing medication. For short-acting agents like alprazolam, I would recommend transitioning to a longer-acting benzodiazepine like chlordiazepoxide or diazepam. I've also used clonazepam in the past. ASAM is particularly fond of phenobarbital. Importantly, ASAM recommends against transitioning to a longer-acting agent in elderly patients given the increased risks of falls and sedation. Heather Ashton was a British physician who spent her career researching and managing benzodiazepine dependence. This website here, benzo.org.uk, can provide and provides a number of different examples of tapers that you can look at. If appropriate, we can consider offering CBT or cognitive behavioral therapy and supportive psychotherapy to help manage the underlying condition and some of the psychological distress that may come with this process. So it's important to remember that unlike opioid conversions, this is not an exact science, and these are not equivalent doses. There's a lot of variability in these conversions depending on the source, so take it with a grain of salt. I recommend that if you're converting to a long-acting, you start a little lower than the anticipated equivalent dose and then titrate up if needed. Again, I know that ASAM is very fond of phenobarbital. I do like it for its very long half-life and auto taper, but we do need to be cautious and avoid it if the patient has any drug-drug interactions, patients with liver dysfunction or cirrhosis, and it's not recommended for use in the elderly. Some people, particularly those who have been on high-dose rapid-acting benzodiazepines for a long period of time, can experience protracted withdrawal or benzodiazepine-induced neurologic dysfunction. These symptoms can last many weeks to months beyond the expected time frame after discontinuation. These aren't necessarily medically dangerous symptoms, but they can make people incredibly uncomfortable and can drive return to use. So it's really important about educating people about this. And also you might need to use some adjunctive medications, particularly in the setting of things like hallucinations and psychosis. In my experience, those typically don't last very long, but certainly some of the cognitive dysfunction, poor memory, distractedness, GI disturbances, those can last for months. A way to address protracted withdrawal, typically this occurs actually with prolonged use of high-dose rapid-active benzodiazepines like Xanax or alprazolam. But a slow taper can reduce the risk of this occurring. Off-label, we can use medications like gabapentin or pregabalin to help with this. So just a few points about patients with underlying psychiatric conditions. We want to optimize non-benzodiazepine pharmacologic therapy as much as possible. Refer to psychiatry if needed, refer to CBT or other psychotherapy interventions. We definitely want to avoid use in PTSD. So again, benzodiazepines do not improve sleep quality. They're also associated with an increase in depression, aggression, and substance use, and they decrease the overall efficacy of psychotherapy. It makes people a little bit less able to participate and experience the emotions that they need to experience in order to process their trauma. We want to prioritize sleep in patients with bipolar disorder or history of mania, so tapering too quickly can definitely trigger decompensation, and we may need to be adding in some medications to help ensure that they're getting good sleep at night as much as possible. In addition to that, CBTI, which is the CBT or cognitive behavioral therapy for insomnia, which is the first-line treatment for insomnia. We always want to screen for mood symptoms, active mood symptoms, in particular suicide, and refer patients appropriately, and then again refer or coordinate with psychiatry. So the American Geriatric Society has included benzodiazepines on their Beers criteria list, essentially as medications to avoid in the elderly. Adults over the age of 65 are more sensitive to benzodiazepine effects as a result of metabolic changes, decreased hepatic and renal clearance over time, cognitive changes, loss of function, balance, falls. Many older adults are already on numerous medications, so we need to really ensure that we're reviewing the drug-drug interactions. And so generally speaking, we want to, unless there are compelling reasons to continue and the benefits outweigh the risk, we do want to slowly taper. Sometimes it can be very helpful to engage family, have pill boxes and a written plan for patients. Generally, it's not advised to switch to a longer-acting benzodiazepine for tapering. Even if folks are on a short-acting, it may be better to just go very, very slowly over time, unless there are more urgent medical reasons or reasons to discontinue earlier. So patients with co-occurring substance use disorders, it's really important that we're screening for active use, offering appropriate treatment. ASAM does strongly consider a taper for individuals with active substance use disorders, especially if they have alcohol use disorder or opioid use disorder, because it really does increase that risk for respiratory depression and death. Folks may require inpatient or medically managed residential settings in order to more rapidly taper. Importantly, we really do not want to discontinue or disrupt medication for opioid use disorder like buprenorphine or methadone. These are life-saving medications, and we don't want to stop them just because somebody is on a benzodiazepine or is started on a benzodiazepine. Just remember that methadone is not, again, on the PDMP if it's being dispensed for opioid use disorder. I also want to say we want to ask people, this has been coming up more and more recently, that we want to ask patients about kratom use or use of 7-OH is at higher doses. That is an opioid that can also contribute to respiratory depression if it's combined with a benzodiazepine. And we want to prescribe naloxone or Narcan for folks. So I have another case example. This is Ben. He is a 36-year-old man with alcohol use disorder and anxiety who was prescribed clonazepam by his primary provider. However, due to ongoing alcohol use, the benzodiazepine was discontinued via rapid taper. Ben then turned to the internet and began purchasing what's called bromazolam, and he presents to the emergency department in benzodiazepine withdrawal because he was not able to fill a script, he was not able to obtain it from the internet. So in the emergency department, we typically see patients who are withdrawing from non-prescribed benzodiazepines or polysubstances, folks who are not tolerating a benzodiazepine taper from their regular prescriber, or who have lost access to their benzodiazepine prescription. It's important that ED providers attempt to coordinate with primary prescribers, screen for substance use disorder and risk of substance withdrawal, consider admission if folks are at high risk for complicated withdrawal. If they're stable for discharge, we want to steer away from providing ongoing scripts, and we want to encourage outpatient follow-up. But we may need to consider a bridge script for some people. Sometimes we can give them a script for a slightly lower dose as appropriate, or initiate a short taper or a taper with phenobarbital, if this is not something that folks are going to be getting in the outpatient setting going forward. And then, of course, establish some kind of follow-up plan, and social workers, peers, those folks in the emergency department can help work on that plan. All right, so designer benzodiazepines are a subclass of novel psychoactive substances which are made when people modify existing drugs and sell them on the internet at a low cost without the requirement of a prescription. Generally, they're not marketed as drugs, they're marketed as research chemicals, and they're designed basically to be like alprazolam or Xanax, high potency, short acting. And because of the variability of regulations, it's really challenging to restrict access. It's also challenging to know what these designer benzodiazepines are really composed of, and so they do pose public health risks. These substances are not always picked up on a GCMS or a confirmatory benzo test, but it's important to test because they may also contain synthetic opioids or other contaminants. So last summer, 27 people were hospitalized for overdose in West Baltimore because a designer benzodiazepine called N-methylclonazepam was added to a batch of fentanyl. The addition of the methyl group to clonazepam created a very powerful sedative, and Narcan or naloxone will reverse the fentanyl, but not the benzodiazepine. Generally, designer benzodiazepines do have similar properties to the approved or known benzodiazepine and should be reversed by flumazenil if that's needed in an emergent life-threatening situation. So back to Ben. So while he's in the inpatient setting, I would trial him on a very low dose of phenobarbital, 16.2 milligrams 3 times a day, and watch him. Some providers might be more comfortable with chlordiazepoxide, and that's fine too. But Ben is likely someone who would benefit from inpatient substance use treatment if he's in agreement. And in my experience, many treatment facilities will continue to taper folks over the course of a week or so, as long as you provide clear instructions. And finally, we can't prevent diversion, but we can reduce the risks by screening for substance use disorders, implementing short scripts, frequent check-ins, pill checks, written agreements. One of my colleagues brought up a great idea of creating a written signed document similar to the Start Talking form we have for opioids. Start Talking form, I hope I said that right. Of course, reviewing the PDMP, and I think the most important thing is to have open, honest conversations with our patients. We should be sharing our concerns and creating an environment where people feel comfortable disclosing information to us. That's all I have. There's plenty of time for questions.
So one question that was asked was, what medications have you found helpful for patients to use as needed for anxiety without benzodiazepines?
Good question. Yeah. I generally have found things like hydroxyzine, clonidine, guanfacine, propranolol. Sometimes I have used short courses of second generation antipsychotics like olanzapine, Seroquel. Obviously, those are things that you really want to limit the use of and not get people stuck on over time, but I have used them. Those are generally gabapentin, if I didn't say that already, pregabalin help with that as well.
Okay. Do benzos cause ED in men after prolonged use?
Oh, I have no idea. I know opioids do. Do benzodiazepines? That's a good question. I'd have to look that up. I'm not sure. I mean, it's a muscle relaxant, but I don't know. That's a guess.
What can I recommend to a patient who works night shift and has a history of insomnia and hypertension, which is controlled? He used melatonin, but it was not helpful.
So sleep medications, sleep is tricky because again, like nothing gives you good quality sleep. So, and I feel for people who work night shift because it's very challenging. Trazodone is a commonly used medication. Sometimes it gives people nightmares though. And not everyone, or very vivid dreams. So that would just be something to caution. And then I have seen Seroquel be used. I don't love it, but patients often like it. Lower doses, like 25 to 50 milligrams. I'm not a big fan of the Z drugs, which I didn't talk about today, but are, also act on the benzodiazepine receptor. Clonidine sometimes can help patients if they're really, kind of have a little bit of that fight or flight happening before bed. But honestly, I would try to steer clear of, see if there are any non-pharmacologic things. So any of those like classic interventions that we do in terms of, making sure the phone is away for an hour beforehand, taking a hot shower if possible, creating a routine if that's available to them. Anything kind of soothing and sort of behavioral interventions, frankly, are going to be more successful. I know that's not a great answer, but
Is gabapentin ever used in patients having difficult time sticking to a benzo taper to minimize withdrawal symptoms and protect from seizures?
Yes, it is. I would say if you're concerned about patients having seizures, then I would not use gabapentin at the front. But it can help with some of that post-acute withdrawal, and it depends on. I mean, usually, like a starting dose for that would be something like 300 milligrams 3 times a day, but you can go up from there. I mean, obviously, it's renally cleared, so you need to look at their kidney function, but that's an option. Yeah, absolutely. I've used that. I've used it in mild withdrawal on its own, and I've used it in the post-acute withdrawal period, in addition to Lyrica or the pregabalin as well.
Is there a dose threshold that is more concerning when taking benzos concurrently with buprenorphine?
I mean, the higher the dose, the bigger the risk, right? I mean, a th- I don't have a threshold necessarily because it really depends on how long somebody's been on it for, right? Their tolerance. Um, but I would say, you know, it's hard to say. I mean, again, you don't want to stop the buprenorphine. If you can at all taper the benzodiazepine, it's it's usually wise um, to do so. And really, we're trying to find the lowest effective dose. I think again, it just really depends on what the agent is and how long the patient's been on it. But any movement on a taper is movement in the right direction, positive direction, and reduces the risk.
For a low dose of Xanax PRN for a 30-day script for a new patient, what is the frequency or threshold we should recommend for patients in order to reduce risk of dependence?
Um, what's Can you repeat the question?
Yeah. For a low dose of Xanax PRN for a 30-day script for a new patient, what is the frequency or threshold we should recommend for patients in order to reduce risk of dependence?
Um, I'm not sure frequency of what of like follow up of. Um, I mean, I'll say you know, we
I
again
think
we want to. Yeah, go ahead.
maybe the question might be, Liz, is around like how kind of much and how often, like what sort of instruction would we give the patient to lower their um or reduce their risk of dependence, I think might be they're asking.
Okay, so that chart that I had earlier, that's part of ACM guidelines, is really helpful here. I think so. If they're using it, 3 days a week or less, then they really don't have much risk of developing tolerance. If they're using it 4 days or more, their risk of tolerance, they're going to have a higher risk of developing tolerance, and it's going to be harder to come off. You're going to have to taper them if they're using it if they're using it regularly, and it only takes 2 to 4 weeks of regular use to
Mhm.
develop tolerance, right? So that is something to be aware of, right? And so I think, especially at the beginning, if you're providing a new script, it's important to check in frequently. I would check in, at least after a month, find out how many they've required, and if it's something like they're requiring it every day, then I would really consider, either giving them an SSRI or an SNRI and seeing if they're open to that, right? Because that's talking more in the like maybe you have more generalized anxiety or more is something else that's kind of underlying, um, and yeah, go from there.
Mhm. I think you brought up an interesting point that I hadn't thought of yet about the start opioid start talking form. And of course, we do that with all of our, new patients that are starting opioids, including actually we have to do it for those that are starting MOUD as well, since it's partially an opioid. But hadn't thought about it for patients on benzos. And I know we had a comment like as people were registering for the webinar about kind of like informed consent and sort of the, I think, idea behind the start talking form and documenting that. That's an interesting idea.
Yeah, I think it would be great. I think a lot, I imagine you're going to get, a proposal to do something like that would get a lot of pushback
Hmm.
because it's really such a divided topic. I mean,
Yeah.
there's so many articles out there about how benzodiazepines are, should be first line, are incredibly helpful, and how, the anxiolytic properties, people don't develop tolerance to the anxiolytic properties over time, which accounts for the fact that so many people are able to stay on the same dose and don't develop an addiction over time. But that's not for everybody, right? And so, how do you predict who would benefit from? I mean, I think everybody would benefit from a form like that because really it's just information, right, about
Mhm.
safety. It's not like um, you know, it's not like it's just information. So I think I would imagine you probably get some pushback, although I don't think it's necessarily warranted. I think it would be we could try that. We could try to
Mhm.
push that through.
Oh, awesome. Thank you.
Yeah.
There's one more question in the chat. It might be helpful if you're able to click on the Q&A box, Liz, at the bottom of the screen. It might be helpful to read this one as well, um, about starting with someone who's on SSRIs and uh,
Uh,
a
we
new start.
we can identify if the diagnosis would be adjusted to bipolar if they have a quick change in mood, right? With the short-term sort of a benzo when initiating, would you be concerned about not being able to identify a switch to mania? I think it's just all about the questions that you ask. I mean, if you're putting them on a long-acting benzo for every day or twice a day maybe, but I don't think that I think you I mean generally I haven't ever put somebody on enough benzo for their mania to be controlled adequately. So I would imagine that you'd still be able to detect it to some extent. I mean, right? Maybe it's going to be a little bit more subdued. Maybe you might have, a little bit more irritability. But honestly, that would be even more evidence, frankly.
Awesome. Thank you.
Yeah.
Yeah.
So, I think that about wraps up the Q&A portion, and we are getting close to time. So thank you again, Dr. Hoffman, for a wonderful presentation, and thank you for everyone for joining us. You will receive an email with the CE information if you haven't gotten that already. And I hope everyone has a good rest of their afternoon.